and look forward to following up with him on a number of issues. So we are going to shift gears now for the afternoon. We had a little bit of discussion about state issues this morning. However, this afternoon we're really going to dive into those issues. As many of you know, RAAP has been involved in a number of state issues across the country, whether it's copay accumulators, PDAB, prescription drug advisory boards at the state level, implementation of those, as well as working with some of the state-based organizations for legislators to help them get better awareness and understanding of rare disease access issues. We are very pleased that we are moving forward with a project with the National Conference of State Legislatures, where we are working with them to build a state patient access focused committee within NCSL. And so this is a first step to hopefully having broader conversations with state policymakers in an area where they feel comfortable, they're with their colleagues, and we can talk to them about rare patient issues. And so this is really a big step forward, and we are excited to be partnering with them. With that, I'd like to introduce our moderator for our next panel. Tara Britt is a member of the RAAP board, and she has been extremely involved in a lot of state issues, including newborn screening. And so Tara will be moderating the panel and introducing her panelists. So we'd like to turn the time over to Tara.
I want to thank Garrett, first of all, from Tillis's office for stopping by. We had such a great conversation yesterday about rare disease, and he makes me proud to be from my state in North Carolina when I'm not always that proud when it has to deal with rare disease issues. So we've got a lot of work to do, and I'm just very thankful for people like him that are very invested, and for Senator Tillis as well. So I am very passionate about newborn screening. I was in San Antonio last week at the Women in Government Conference and talking about this on a panel. And I start out and end the same way. Newborn screening saves lives. And I heard Britt and the previous panelists talking about the long, diagnostic journey and about moving from state to state because, every state differs. There's not like a federal regulation. Like with newborn screening, we have the RUSP. That's only recommended uniform screening. And currently, there are 4 million babies that are born and their families benefit from newborn screening through early detection of the disease and the delivery of life-saving treatments. 12,000 of these babies will be identified with a newborn screening condition each year. And newborn screening is widely accepted as one of the largest and most successful disease prevention programs in the history of the U.S. CDC recognized newborn screening as one of the 10 most important public health achievements of the century. Now, this number might be different, Dylan, you can probably correct me, but this is based on some information I had in the past. Currently, 33 states do not screen for all of the federally recommended conditions, leaving hundreds of babies undetected without timely treatment each year that often contributes to early death of these babies. What we call this, or what I've been learning from patient advocates that I work with across the country, they call it death by zip code. Because we do have the recommended uniform screening panel, and because it's only recommended, I can remember talking to one of the patient advocates in Louisiana, and she said, if I had lived 2 states over, my child would be alive today. That's just, I don't have words for that. So with that being said, I was talking to Garrett about this yesterday, and I've been working with Klobuchar's office a little bit about this. I really feel like it should be more mandated for states to have to follow these, but I know that there's budget issues, and Dylan's going to talk a little bit more about this coming up. But anyway, my name's Tara Britt, and I am founder and president of the Rare Disease Innovations Institute that was started in North Carolina initially. I co-wrote with a patient advocate, and I have to give her full credit because it was her idea. We co-wrote legislation to form the first rare disease advisory council in the nation, and that's in North Carolina. Now we have, in North Carolina, I've got new legislation in to expand our council. Now, if only some of our legislators would want to hear any bill on health care, then we may get somewhere. So I'm worked with a lot of state legislators. I was in with my friend Laura Bunnell here, who is a mom to 2 cystic fibrosis children, and we were testifying on the Michigan floor a couple of weeks ago with their RDII. So there's a lot of important work going on with this. I just feel like, I think that's just the saddest thing to say. I live in a state that my child would have, lived if I had lived in this other state. And you're almost penalized, especially people in the rural areas where I'm speaking from North Carolina, but it's all over in the other rural areas. They don't have access to the same type of health care. I live 20 minutes each from Duke, UNC, NC State. Wake Forest is not that. So we are home to the center of excellence for so many of these rare disease. We have Terry Klein here, head of the MPS Foundation. It is just, every state has issues. You just have to keep plugging on and trying to make a difference. So with that being said, would you like to please introduce yourself and then?
Hi, so again, my name is Dylan Simon. I'm the Director of Policy at the Everylife Foundation for Rare Diseases, where we focus on development of and access to rare disease therapies, cures, and diagnostics. So here, obviously talk to you about the diagnostics portion. And so before I kind of jump into newborn screening and the role of that, and Cynthia will talk a little more on the general diagnostic section. Dean cited some of these numbers earlier, but I think they're always important to be repetitive on such impactful numbers. But from a 2020 study of the National Economic Burden of Rare Disease Study, we're able to show that in 2019, the cost of the rare disease to the healthcare system was just under $1 trillion at $966 billion. And to Dean's point, that was only looking at 379 rare diseases, which is obviously a very small portion of the known 10,000 rare diseases. And so within that cost, 60% of that was non-direct medical costs. And so we know that this is not just inpatient visits, not just outpatient or prescription drugs, that we know that this is lost income, what the cost of installing a ramp in one's home. And so we know that there are a lot of costs associated with that. But in addition, we also know that within the direct medical costs, that the largest driver of direct medical costs was inpatient visits. And so the reason I highlight that is because we took that as well as additional information around the Diagnostic Odyssey, which states that it takes on average just under 6.5 years to receive diagnosis within the rare community following the onset of first symptoms, and often can require can require patients to have to visit almost 17 specialists before they receive their diagnosis. And so the Everylife Foundation wanted to really kind of dive deep into what is the cost of the Diagnostic Odyssey. And so we were able to publish a study earlier this year that really looked at that. And really at the core of that is the fact that we were able to show that on average, looking at 7 conditions, 5 of which are pediatric onset, and 3 of which are actually currently being screened almost nationwide on newborn screening panels, that the average cost was $220,000 per family during the delay of receiving the diagnosis. And so that range, there was a huge range from anywhere between $86,000 to just over $500,000 per family during the cost of that delay. But within the newborn screening space, we know that that has such a huge impact, because when we're looking at those numbers, we're looking not only at medical costs, but we're also looking at lost income. In addition, we're trying to understand essentially the productivity loss, and so we were looking at, okay, what is the cost of having to go to an inpatient visit? And so there had been studies out there that suggested that we associate that with 1 day loss of work productivity. We also know that's an extremely conservative estimate. That's if you're close to your doctor, if the doctor is even in your state. And so if you're having to cross multiple state lines for that inpatient visit, we know that you're losing more than a day along the way. And so that also paired nicely with what we'll get more into the newborn screening space, is because when of the 3 conditions, which were SCID, Pompe, and ALD, which include within that study, you saw huge differences in terms of the cost associated with the family with that Diagnostic Odyssey. Because when a condition is included within newborn screening, that cost goes to 0, because you have that early, timely diagnosis. And so that pairs well with our newborn screening modernization white paper that we put out in September as well. And I'm not going to go fully in depth into some of the proposed solutions. I'm happy to answer questions about that later on, but it really kind of fell into 4 key themes. And those 4 themes, really we're looking at how do we modernize newborn screening and ensure the fact that it does remain one of the most successful public health programs. But we also know that there are challenges that exist within the program today. We know that the incoming wave of innovation, both on the screening as well as therapy side, is going to lead to more and more communities wanting to utilize newborn screening as a diagnostic option. And we want to ensure the fact that the communities that have the data, that have the evidence that support the addition to newborn screening panels are being added as quickly as possible. And you're not getting situations such as an MPS II, where you had an FDA-approved treatment for 20 years before it was officially added to the federal recommended panel. And delays like that is not just, those are lives. Those are lives that we weren't able to provide that early diagnosis for that amount of time. And so what we looked at was, again, those 4 key themes. So the first was looking at increasing federal accountability, transparency, and leadership on this issue. States do play a major role within newborn screening, and I can talk a little bit more about that later. But at the end of the day, these are national issues. When you're having to cross state lines to see a specialist, when the committee that oversees the addition to the RUSP is a well-staffed, volunteer-staffed committee with experts from around the country, and it still takes them at a minimum 9 months to truly understand the evidence behind it, asking every single state's newborn screening advisory committee to then go through that data themselves is asking a lot. And so we know we need more federal leadership. We also know that the Federal Advisory Committee was set up in its current form in 2008. Since then, a lot has changed. Primarily in 2017, we saw the first FDA-approved cell and gene therapy. We know that's going to have a huge impact on the newborn screening system in terms of who has the FDA-approved treatment, who has the care standard available to meet that requirement to be added to newborn screening panels. And so to really call for new federal leadership on this issue. The second is really looking at more of the state aspect of how do we help the regional lab, how do we help labs add these conditions? And so it really looks at how do we properly implement a regional lab network? Because the times of asking every state to do everything is probably behind us. We need to recognize that these labs, the resources are short, and to ask them to all of a sudden to find that gap of what they have versus what they need, it might be asking too much. So how do we ensure the fact that the expertise that is out there, because you take a moment to, if you have the opportunity to speak to these state lab directors, speak to the programs themselves, you know that the expertise is there. It's just a question of a resource and being able to leverage that expertise. So how do we create a regional lab network that can allow for that to work best? And so the third theme was really looking at data collection, and it was really how do we ensure the fact of increased transparency around data to ensure the fact that what works best is being implemented across the country. In addition, you hear a lot of conversations around, well, we don't necessarily have the data to support this. And so if we can continue to show that when you have what some may say not enough data at the beginning, that's a lot of that's, especially in the rare disease spaces, because we're dealing with small disease populations, that developing the data set that they hope to have may not be as possible as they think, but that we know that if you have, you can have a strong data set from a smaller population, and then you can see moving on, such as SMA, that there is huge impact when you actually add it, and so increasing that data transparency. And lastly, which I think will pair nicely and lead into Cynthia's conversations, is how do we properly integrate genetic testing? Genetic testing is already done in some fashion within newborn screening, typically on the confirmatory side of the program. But there are lots of conversations and lots of studies being done on how to integrate genetic testing into the full newborn screening program and have it be more of a potentially more of a first-tier test or second-tier test as opposed to a confirmatory test. However, that is not as straightforward as one may think. And so making sure that we are not getting lost in the coolness of the technology. My educational background is actually in the sciences. I worked in a microbiology lab for my grad school work. And so I'm well versed in the, this is a really cool new scientific toy. And genetic testing is that. And I don't want to belittle that fact. The technology is amazing. But the technology has to fit into our public health system. And during the roundtables that led up to this white paper, there were multiple state lab programs and state lab directors that said in that roundtable, we love genetic testing. We think it could have a huge impact. We just aren't prepared or able to integrate that into our program. And so that is not a nothing statement. These are very smart people who want to do good, who have spent careers in state lab programs, working hard and earning less than they can get in other places, who are saying, we just can't do this. And so making sure that we're taking the time to step back and say, how do we properly integrate this that's going to ensure the fact that we're improving equity, not creating new inequity? And so with that, I'll pass over to Cynthia.
Great. Thank you, Dylan and Tara, and thank you, RAAP, for inviting me to participate on the panel today. For those who I'm not familiar with, my name is Cynthia Benz, and I'm the Senior Vice President of Public Policy at an organization called the Personalized Medicine Coalition. I've been with the organization for 6.5 years now. Before that, I spent more than a decade at an organization called the Alliance for Aging Research, focused on aging issues, Alzheimer's and physical frailty in particular. So if you would have asked me back then if I would be sitting on a panel about pediatric rare diseases and also being having a family member who was recently diagnosed with a rare disease, I would tell you I don't think so. My family has a very interesting gene pool, but it's a very messy one, and it's one of the reasons why I love working at the organization I do so much. But just a little background on the organization itself. It's been around for 20 years. It started as 13 members, and at the time, it was around the time of the sequencing of the human genome, and about 13 individuals came together to say, just because the science is really cool, it doesn't mean that every patient is going to have access to it. So we need to find a way to work through some of the thorny issues to make sure that science-based innovations are incorporated into the healthcare system appropriately, and so everyone can get what they need. And one of the things that the organization's used as a benchmark for the last 18 years or so has been what percentage of approvals at the FDA are actually considered to be a personalized medicine. So that would be something that has some genetic or genomic basis for either diagnosis of the disease, whether or not it guides treatment or removal from treatment. What we found when we first started looking at approvals in the personalized medicine space, there was less than 5% of the new drugs that were approved by FDA that would be considered a personalized medicine. And at that time, it was 100% of the drugs were in oncology. Over time, that number has grown. In 2018, about 42% of all of the new drugs that were approved by the FDA were personalized medicines. And this is where RARE comes into play. Instead of 100% being in oncology, more than half of the drugs were outside of oncology, and that was split between both rare diseases, common chronic diseases, and infectious diseases. For 8 years, the percentage of approvals at FDA has been about a quarter personalized medicines, but we still see that sort of increase in the number of products that are approved being in the rare space. What we found when we started looking at issues around whether or not the system was prepared to actually take up some of these therapies outside of oncology, we took some learnings from oncology and looked at what was leading to a lack of utilization for personalized medicine oncology products. And the vast majority of problems with patients not getting access to treatments in oncology strictly were focused around the healthcare system not being equipped to be able to handle the pace of innovation that was coming to them, and a lack of clarity around the coverage and reimbursement environment for diagnostic tests that were guiding treatment. And just a sobering statistic in oncology, we did a study on non-small cell lung cancer this year, and any of you who actually still get commercials on your TV will know that non-small cell lung cancer is basically the alphabet soup of biomarkers that fit to guide your treatment. And still in oncology, we only see about 36% of patients getting access to targeted treatments that they're potentially candidates for. So if we can't get personalized medicine delivery right in oncology, how on earth can we expect to get personalized medicine right for patient populations where you have maybe 10 patients who could get access? started looking into the genetic sort of testing environment for rare diseases. And what we found is there are just a varying suite of things that you see for EB that Britt spoke about earlier, his daughter's condition. It's a monogenic condition, so there are actual single gene panels that can be used to diagnose and confirm that if it's something that a doctor suspects that a patient might have. There's multi-gene panels. Where multi-gene panels have been shown to be pretty effective is if you're dealing with epilepsies. Epilepsy is not just one thing. There's a number of different kinds of epilepsy. Some of them are actually treatment resistant. And being put on a treatment for epilepsy could be really problematic for that patient and that family. And we've worked with a patient's family who they had their child diagnosed with a number of things before epilepsy, but until they had a multi-gene panel, they actually didn't know that their son had treatment-resistant epilepsy, and he was put on treatment, and they spent more time managing side effects than actually dealing with his seizures themselves. So he was markedly better once he had that testing. And then you get into the really, really cool technologies, I would say, things like whole exome and whole genome sequencing, and that's really where there's a lot of promise for some of the conditions where, you have pediatric patients present in an intensive care unit, they're, very ill, no one knows what to do, and in those cases, you need as much information as possible, so in those cases, something like whole exome or whole genome sequencing can be most beneficial. At the top end of testing for whole genome sequencing, I would say that the most expensive that it would be is $15,000. But if you're dealing with a patient that can get on a treatment that's going to change their life, I would say that that is something that's totally worth it. It's actually coming down in price now. It's been a lot. It's a lot more commercially available. But the problem is that we're finding that in states, someone did a great job of explaining on one of the earlier panels the number of pediatric patients that receive their care through Medicaid. And most states don't cover genetic and genomic testing. They don't have consistent policies. They don't have clarity around, what should be available to patients. There's a lot of denials. In some cases, the testing is considered to be experimental. And I would say that if the most expensive and most complex of the tests were commercially viable 6 years ago, it's unacceptable for us to say that this is something that's experimental. It's beneficial. So, we have been really fortunate to work with the rare disease community, and just about everybody who's an advocate in this room has worked with us on federal legislation that I can go into more detail about. But it would do a number of things. It should provide guidance to states that they should already be covering this through their existing benefits. It would establish a 3-year pilot. Britt spoke to the 1-year window that most states have. This would take it outside of the 1-year window to provide financial assistance to states to actually cover the testing, to collect data on whether or not this is something that's improving patient outcomes. And then, by and large, we want to see this become something that doesn't become a state decision, that is something that is available to patients in all 50 states. And so it would also provide for a study for how we could responsibly do this for every state. But I'll stop talking and let's see.
No, this is really good, and I want to echo to what Britt was saying earlier about the diagnostic journey and how it takes, many cases so long. I had a friend that died a couple of years ago of HHT. The average diagnosis time for that can be up to like 18 years, and unfortunately, she passed that on to 2 of her daughters, and it's fatal by the time you're in your early 50s. And what Britt mentioned earlier, and I was talking to Garrett about this in Tillis's office yesterday. I don't quite get it because if you catch it early, it does save money in the long run. But I also would like for you all both to expand on, I hear this quite a bit when I'm working within the states. We're very fortunate in North Carolina. We have quite a few genetic tests, counselors, geneticists, and UNC, Duke, and other places. Talk about these states and what are the issues maybe going across state lines for genetic testing. Do you all have any input on that? With so many states that don't have it.
Yeah, I would say most of that's driven by the centers of excellence or areas where there are providers or research that's being done in specific diseases. I would say things like whole genome sequencing, there's already efforts in the states to provide coverage for them for patients up to a year of age in some cases. But when you're looking for that answer and you need to get it quickly, you'll go wherever you need to do that. So I think that's.
Yeah. Why don't you Cynthia, talk a little bit more about the Kids Act?
Oh, sure. We're going to call it, we can call it whatever we want as long as it gets done. So the Precision Medicine Answers for Kids Today Act was a bill that was introduced in 2021 initially, and it was a product of a number of years of discussion among stakeholders on what it was going to take realistically to move forward on making sure that there is access to genetic and genomic sequencing. There were competing proposals, I think, at the time of whether or not everyone should back a specific technology and push for that to be covered in all 50 states. I believe at the time, and still continues to be the case, that the consensus is that, you know, if a patient needs access to a monogen or a single panel test or a multi-gene panel test for their disease, that's something that should be covered, as well as everything down to whole genome and whole exome sequencing, which still is largely uncovered in most states. And what we think is really important about the legislation is that, you know, there have been studies, and our organization, the Personalized Medicine Coalition, has put out studies to show the potential cost effectiveness for things like whole genome sequencing following the current guidelines for diagnosis. So we look to the American College of Medical Genetics for the guidelines that they put out for use of whole genome sequencing in pediatric patients. And they do recommend it as a first line for certain congenital abnormalities and neurodegenerative diseases, and a second line for patients who haven't gotten a conclusive diagnosis using other types of standard of care. And just looking at that, and I would say we use QALYs in our study, which is you know, something that we shouldn't talk about, but even using something that's, you know, potentially discriminating against a number of different populations like the QALY, it actually showed that under conservative assumptions that whole genome sequencing and whole exome sequencing are cost effective and being used in a wide variety of populations. And once you get outside of that 1 year time window, it's less clear. So there should be these other options available. And we use that, and we take it to the Hill and we say, you know, how can you argue that when you have treatments that are coming to market and the deciding factor between whether or not a patient gets on this is a definitive diagnosis, and in some cases, if it's a progressive disease, getting that diagnosis early, how could you argue that this isn't something that your boss should be supporting because the testing itself is cost effective? And so, you know, we were fortunate that we found champions in the House and Senate to take up the mantle. The Precision Medicine Answers for Kids Act is the House version of the bill, and it does cover the widest variety of tests. And the first thing that it would do is clarify from CMS the guidance to states that's required to show that this type of testing should already be covered. They have something called the Early Periodic Screening, Diagnosis, and Treatment Benefit in Medicaid, and there is no way of looking at that to say that you shouldn't be covering these tests already for patients who need it. End of story. The bill, once it provides guidance, it then looks to establish a 3-year pilot program in up to 15 states where states can apply to be a part of the pilot. And in doing that, they would be able to get assistance to be able to offer this test. And it gives preference to states that financially can show that they can't otherwise afford to do it. But you do need to collect the data to show that this is something that, you know, why you're denying any claims that come through. What are your criteria for providing coverage? And, you know, what are the outcomes from that? And we think that that's something that's really missing and would be beneficial from the legislation. And then the last thing I'll mention is the National Academy study. This is something that was an idea that Congressman Swalwell had many years ago, was to look at a National Academy study to advance precision medicine in all disease areas. Right now, it's included in the legislation as a way to build off of the pilot program to make evidence-based recommendations for how you can broaden coverage to all 50 states. I think we've found ourselves in sort of the challenging place of, you know, how much is this going to cost? You know, in an environment where a lot of people don't want to see I think the heavy hand on what Medicaid programs should do, getting bipartisan support for it this year for reintroduction, but we're working really hard to do that. So if this is something that you care about or your boss cares about, would really love to work with you on it.
Thanks, Cynthia. Okay, Dylan. North Carolina was very thankful for you. I was very thankful for you, and working with our state newborn screening lab director. And Terry remembers this day too, because we were so excited when we added MPS ALD, Pompeii to our newborn screening, and then you said, hey, let's put a time limit on when. So COVID hit right after we added this. And our state lab director is wonderful, Scott Schoen. He is a leader, a true leader in terms of state lab directors. I did feel sorry for him because during COVID, I harassed him on a regular basis. Why is this not moving forward faster? We have COVID. Well, we have kids dying of rare disease. That's just how it is. So there are challenges. I would like to ask you from the Everylife, and I love working with the Everylife Foundation, I have to say that. So what are the challenges going into states with enacting this type of legislation like we did in North Carolina to put a time limit? What do y'all see as your challenges going into the various states? Because we don't have enough guidance from the federal level. We might have some guidance, but it should be at a federal level where these rules are. So talk a little bit about that.
Biggest challenges is typically the funding side. A key part of our legislation is making sure we don't want to create unfunded mandates. So we don't want to create a situation where we say you have to screen for this condition in 3 years and hopefully you can find the money. Because we know that in general, public health is underfunded and state labs are no different, and state labs are much more than just newborn screening programs. And so what we don't want to do is create a situation in which they're having to move money around from another important program to cover newborn screening costs. And so a key part of that legislation, which North Carolina actually already had when we went into pass the legislation, was how do you ensure the fact that there's a long-term funding source? And so that can come in a variety of ways. Newborn screening is unique because there are a set of newborn screening fees that are already covered by insurance. And so increasing those fees typically is, from a cost perspective, pretty easy. From a regulatory perspective, is a nightmare because the fee typically has to go through the rules process, which can be complicated. I will say we're actually working with legislation in Wisconsin this year, and their rules process is unique in the sense that if the Department of Health puts out or any department puts out a regulation or a rule, then it then goes to the state assembly, and the state assembly has the ability to approve or deny any proposed rule, and that complicates everything. Which is a long way of saying states have unique rules process, and so getting fees increased is the cleanest way, but still a challenge. However, with a newborn screening, there's always going to be a potential kind of what I call an upfront cost to adding a condition. So when adding new condition is going to require validating the test, ensuring the fact that you have the right equipment, potentially hiring new staff, and all of that is going to be kind of new upfront costs. And that's where you get to the appropriation side. And so that's where, in some states, we'll work to ensure the fact that there's required appropriation requests to be included in governor's budgets. But again, just to go back to the beginning of the question, the biggest challenge is always just getting buy-in from the department that we're not trying to create a situation where they have to screen for something and they don't have the funding to do it. We want to work with them to ensure the fact that there is funding to support these programs.
Okay, thanks, Dylan. Okay, so Cynthia and Dylan, do you have any last-minute points that you want to make before we ask the audience to ask questions?
Yeah. So those of you who work for congressional offices, we would love your assistance on a couple of things. So first is there was report language at the end of year package that went through last year that actually calls for the CMS guidance to states on the EPSDT benefit. CMS is working on it. So to the extent that you or your boss is so moved, if you all could put a call into CMS and encourage them to produce that guidance, that would go a long way in jumpstarting what we've been working on and potentially remove something that is not necessary for us to push for in reintroduction of the bill. The second thing is if you work for a Senate office, there are differences between legislation in the House and Senate. The Senate version of the bill is very focused on whole genome sequencing and doesn't actually recognize issues with coverage for testing outside. So other tests that patients are struggling to get access to in states wouldn't be covered with what the state's doing. So we've been working as stakeholders not only on reintroduction reintroduction of the House version of the bill, but trying to seek reintroduction in a companion form in the Senate, and hopefully that will happen with continued effort. And then the last thing is, to the extent that your boss has an interest in diagnostic testing issues across the board, I think if you can employ your boss to focus not just on the treatment side, but also the issues with the diagnostic itself. I think that that's really important. And Connor, who was on the panel earlier, who used to work for Senator Tim Scott, he recognized, and his boss recognized early on, that you could be as enthusiastic as you want to be about sickle cell disease, but the diagnostic side is just as important, which is why Senator Scott was actually the first co-chair of the Congressional Personalized Medicine Caucus. In 2019, he agreed to join, and he actually helped us get our Democratic co-chair in the Senate because he recognized that the diagnostic side was just as important as all the enthusiasm that he had for cell and gene therapy. So encourage your boss to join the caucus as well.
I'll start with everything Cynthia said is correct. So Everylife Foundation is also strong supporters of the Precision Medicine Answers to Kids Today Act. PMC has been great on leading on this effort, and we support the bill and try to engage on this bill wherever we can. And so I'm not going to repeat all the asks Cynthia just made, but Everylife Foundation loves this legislation and would love to really see this continue to move forward this session. In addition, did want to flag that we are working towards reintroduction of the Newborn Screening Saves Lives Reauthorization Act. It was last reauthorized in 2014. It was supposed to be reauthorized in 2019, but we've had some issues actually in the Senate. The last two sessions, it passed unanimously out of the House 2 sessions ago and passed by about 150 vote margin last session out of the House. And so we're still working on some of those challenges in terms of some of the bill language here on the Senate side. But we are planning to reintroduce next year. And so do please be on the lookout for that and encourage your members to sign on as co-sponsors as we try to finally get this reauthorized after waiting far too long. So thank you guys so much.
Thank you. And I think at RAAP, we could put up there, Mike, when we send a follow-up email, maybe put their websites up so that we can drive traffic towards your websites to really get engaged. And so now I would just like to ask, does anybody have any questions for these wonderful panelists?
And I love how we all do what Tara asked. I'm sitting in my seat until she calls me up here. I wish I could do that.
No, this is one thing I'm the most passionate about in rare disease is the diagnostic journey and the newborn screening, because it does save lives. I mean, I can't emphasize that enough. And I think the term death by zip code is so sad, that you're penalized because of where you live or if you're in a poor state. That's not right. Everybody should have the same playing field, in my opinion. Does anybody else have any other?
So in Michigan, we have 1 million people with a rare disease. We have 300 people born with a rare disease every year. Our newborn screening only tests in regard to cystic fibrosis for 60 of the 2,000 mutations. So if you're a person of color, you're not going to be found. You're on your own, good luck. You're going to have a late diagnosis, you're going to be hospitalized more, round and round and round. In Mississippi, they test for 1 of the 2,000 mutations. Again, people of color, good luck. You're not going to be diagnosed. I wonder if part of the legislation that you're doing, is it aimed at, there has to be federal oversight, right? There has to be, it's such a discriminatory process as it stands right now, and it's extremely frustrating, and it's about money. Michigan is one of the better ones, and I just talked and did a podcast with the whole newborn screening program. They're trying to get grants to cover so they can, test for more of the mutations, but we have so far to go. You can't get in a clinical trial if you're not diagnosed. So you're so behind the 8 ball. There is a huge urgency. Why are we screaming and no one's listening? Story of our lives, right? But that's just a huge, huge thing.
And I've been saying with the legislation, There are criteria that a state would need to meet to be able to receive the assistance to undergo the pilot. And one of the things that it does give preference to are states where there are geographic disparities, or there has been some other financial reason or some other reason why a state has not been able to provide this. So, I think the Swalwell staff didn't want to make it too prescriptive to the point to where a state wouldn't want to apply for the pilot, but it does have some sort of guardrails in there to make sure that it's just not giving more funding to states that are already doing this in a lot of ways, that it's actually looking at states that want to do it but aren't able to. So, yeah, but keep screaming with us. I was just telling somebody earlier, I said, I think the people that we're working with on this legislation now, it's more people outside of the Personalized Medicine Coalition than there are that are actual members. And at this point, what matters is it gets done. I mean, we really just want to get it done.
And just quickly from the newborn screening side for CF, because yes, for me, was kind of my first, when I first started newborn screening, this challenge within CF in terms of the equity issue, in terms of the confirmatory panel, was kind of my first introduction in terms of some of the inequities within newborn screening. And when you're using genetic testing as confirmatory testing, there's broad research, and every geneticist will tell you that there are inequities and that there is racism baked into some of the tests. The research that has been done in terms of is very white, male, and European. And so what do you do when that exists? And so that, I think, gets to the point of when we're talking about how do we integrate genetic testing into a mandatory public health program that in theory screens every newborn born in this country, how do you ensure the fact that you're doing that in an equitable fashion? And so, again, that gets to the larger conversation of how do you properly integrate the cool new toy into a full public health system. And that's a conversation and a question that has to be addressed if we're going to do this on a larger scale.
Britt?
I'll say one thing, besides newborn screening saves lives, genetic testing is going to save lives. It's for the following reason. I am no longer asked if it's a genetic mutation. I'm asked what the specific mutation is, because a lot of the therapies are determined upon the mutation. For instance, read-throughs, right? You have to understand a read-through and a premature termination codons and what the following protein happens if there's a frame shift or whatever. So it will foster more innovation, more investment into personalized medicine with that data.
We like it. Tara's face.
And a point I always like to make, because 100% agree, newborn screening does work for a lot of communities and can work for many, many more. It will not work for every rare disease. And we need to recognize that fact and support efforts such as PMC and that effort in terms of genetic testing on a broader scale. But I saw a question towards the end.
Yeah, and thanks for answering so many questions. I have one that really I wanted to see what your thoughts were, particularly as we move towards genetic screening. You know, there is a huge shortfall in genetic counselors. And the resources, outreach to medical schools, et cetera, to encourage students to go down a genetic counselor pathway. What are the things that you think could help us shore up that area? Because it's absolutely critical to making this work in the healthcare system.
So in terms of a policy, Access to Genetic Counselor Services Act, and I'll say that again, Access to Genetic Counselor Services Act, it's a fantastic bill. It's a step in the process. It would allow for genetic counselors to be covered as a health profession within Medicare and at a cheaper rate than physicians. Medicare is just one of the payers, and so it's not a end-all be-all, but it is an important step forward.
And I would say, you know, when you're looking at things like whole genome sequencing, when you're not just, you know, looking for one specific diseases, but you're picking up ancillary findings of other conditions that, you know, that patient may have or someone in their family might be at risk for, the role of genetic counselors cannot be understated enough. The amount of time that it takes to actually walk a family through that and to, you know, talk about what those findings mean. I mean, it's incredibly intensive. So we're very supportive of the genetic counselors bill, and also, you know, anything we could do to just encourage the career across the board.
And Britt, what were you going to add?
Reimbursement rates are so low for genetic counselors, there's no reason to go into them. Plain and simple. And that has to be addressed at a certain point.
So the access to genetic counsel services would state that it's at 85%, which I don't know how that would relate to current rates. My guess is it probably would be a little higher because it's 85% of what the current medical geneticist is being paid currently. So hopefully, I'd be curious to actually go and double check if that would increase their reimbursement rates, but.
Let's get our biotech companies to actually start hiring them because it's going to be important to look through registries to find out which of these people with which kind of mutations would be amenable to certain types of treatment. So especially when you start thinking of bespoke gene therapies and stuff like that, genetic counselors are going to be incredibly important.
And we just know from the work that we all do at the National Society for Genetic Counselors, who are the ones that have pushed for that bill, one of the main points of resistance is, like, again, what is this bill going to cost? And I think any of us would say it's not going to cost as much as it should because, the role that genetic counselors play in just the whole aspect is really important.
And to that point, our hope with the recent cost of delayed diagnosis study will highlight the impact of a timely diagnosis, because the cost of a genetic test, these individuals have this condition, have these diseases, regardless of how much the cost to do the whole genome sequence. And we have to diagnose them. And the earlier we do it, the more money we save. And we know that if we're ensure easier and faster and earlier access to these genetic tests, we know there's a savings in the long run. And so ensuring the fact that we're increasing access to these tests, because these individuals need to get diagnosed regardless, because they have these conditions regardless. And the earlier we can get that diagnosis to the individual, to the family, the faster we can start addressing the issue, whether that's through a treatment, whether that's through a care standard, or whether that's just simply knowing the answer and enrolling in clinical trials, or just knowing how to address what will be impacting their lives.
I'm so supportive of this bill. One of the areas that we've run into with the mucopolysaccharidosis is that not only with newborn screening, but because of the amount of specialty clinics that have access now to specific genetic tests that can be ran, panels ran across older patients that they're thinking might be a lysosomal storage disease has really been quite incredible for our organization this past year, that we made a strategic decision. And not only do we have social workers that work with us now with families at the time of diagnosis, but we just hired our first full-time genetic counselor. I'm hoping that there will be a gap fixed, that a nonprofit wouldn't have to have this specialty piece. But in the meantime, the families deserve the best. And there are so many questions around genetic testing and counseling and carrier testing and cascade testing around these disorders, that this was where we needed to go. And not just on the pediatric side, but also the specialty care clinics on the older side of the attenuated patients that are going to, I believe, cause many diseases, bring these patients forward. But I'm so appreciative of the work on this, and I'm supportive of it.
Well, I'm just amazed that you did that. And I would say that one thing I neglected to leave out with the Precision Medicine Answers for Kids Today Act is the pilot would actually allow for coverage of children up to 26. And if the EPSDT guidance came out, it would apply to children under 21. And most of the state-based legislation, but ironically, the one state that is actually covering patients up to age 20 is Florida now for sequencing. Britt and I think the same way. But, I think in other states it's for peds under 1 and very limited situations. And in private insurance, it's even worse. They put additional, if they do provide coverage for testing, even more restrictions on who has access to it and additional hurdles that patients need to jump through. So why not until 26? People are still struggling.
Genetic testing, denial letter says there's no therapy that would help, so it's not medically necessary.
Yeah.
That would direct quote. Needless to say, I called them about 7 minutes later.
Okay, do we have any other questions? Okay, if not, I want to thank these panelists. Y'all have been outstanding, wonderful, and thank you all.